let me say, everyone, good evening from Istanbul. Hi, Psycho, how are you? You are still at the same chair, I think. Yeah, wonderful. Okay, so today we will have 10 presentations. Please, we are know that we are very strict. You have just 6 minutes for your presentations. So it will be a criteria for having scores. If you will extend 6 minutes, then you will have negative score, I think. Do you agree, Psycho and Ibrahim?
Yes, of course. This is very important also to follow the rules,
yeah,
and to learn how to present in keep light.
Content is important, but also the timing and the other things are more important sometimes. So that's why please do not extend 6 minutes. And I think we can start. What do you think, Psycho?
Yes.
Yeah, I agree.
Okay, wonderful. So let me announce the first speaker, who is from Turkey, Pınar Kuru Bektaşoğlu. She will present us investigation of possible anti-inflammatory and antioxidant and neuroprotective effect of apigenin in mild traumatic brain injury model. Please, Pınar, continue, and please keep your time. Yeah, thank you.
Hello, everyone. I'm going to present my study about the investigation of possible anti-inflammatory, antioxidant, and neuroprotective effect of apigenin in mild traumatic brain injury model. Traumatic brain injury is defined as alteration in brain function or other evidence of brain pathology caused by an external force. The episodes of traumatic brain injury are divided into primary and secondary injury. The primary injury is the mechanical damage, and the secondary injury contains many mechanisms, and most important ones are neuroinflammation, oxidative stress, and apoptosis. Apigenin is a plant flavone proved to have a number of biological properties such as anti-inflammatory, antioxidant, and anti-apoptotic effects. Its neuroprotective activity has been demonstrated in models of cerebral ischemia, hypoxic ischemic brain injury, Alzheimer's disease, Parkinson's disease, and depression. In this study, the possible neuroprotective effects of apigenin against mild traumatic brain injury were investigated with various parameters. It is thought that the administration of apigenin after mild traumatic brain injury will show neuroprotective activity by reducing inflammation, oxidative stress, apoptosis, and will have a positive impact on corticospinal functions and learning. And visceral male rats were grouped as control, traumatic brain injury and vehicle, traumatic brain injury, and apigenin in 2 different doses as 20 and 40 milligram per kilogram. And under anesthesia, traumatic brain injury was induced by dropping a metal 300 gram weight from a height of 1 meter on the skull. Before and 24 hours after trauma, neurological examination, tail suspension, YNS, novel object recognition tests were performed. 24 hours after traumatic brain injury, the rats were decapitated. Biochemical and histopathological evaluations were performed. In our first results, it has been shown that apigenin treatment reduced the increased luminol lucigenin enhanced chemiluminescence, and these results indicated antioxidant and anti-inflammatory properties of these molecules. As you can see in this graph, luminol shows the neutrophil activation, and lucigenin shows the macrophage activation, which were increased with the trauma and decreased with the 2 different doses of apigenin treatments. Interleukin-1 beta, interleukin-6 tumor necrosis factor, interleukin-10 tumor growth factor beta, Caspase-3 and Caspase-3 levels were measured with ELISA method. And when we evaluated the inflammatory cytokines, an increasing trend was observed in the trauma groups, but decrease was not statistically significant. On the other hand, a significant increase in interleukin-10 levels was observed in the apigenin groups compared to the trauma groups. The caspase family is a cysteine protein that regulates the many steps of programmed cell death, and the caspase-3 is the active form of caspase-3. And when we evaluated the caspases, an increasing trend was observed in the trauma group. And brain injury was graded histopathologically following hematoxylin and eosin staining, and the significant damage score increase was seen in the cortex and hippocampal CA3 and dental gyrus regions, and the ameliorative effect of apigenin 20 milligram per kilogram was shown histopathologically. In the novel object recognition test, a decreased tendency in the discrimination and recognition indices were observed in the trauma group when compared to the sham group. In the most of the treatment groups, values were close to the sham group. In the YNS test, the number of entries was decreased in the trauma groups when compared to the control values, and this response was found to be compatible with the freezing responses observed during the experiment. Similarly, the spontaneous alternation percentages were lower in the vehicle group when compared to the control values. Additionally, an increasing trend was noted in all treatment groups. And finally, the application of tail suspension test to evaluate the corticospinal function demonstrated a significant increase in damage score after traumatic brain injury, and lower scores were obtained in the treatment groups. In this study, for the first time in the literature, apigenin treatment after mild traumatic injury showed ameliorated oxidative stress, inflammation, and neuronal damage. Examining the effects of apigenin in both pathophysiological and functional results in traumatic brain injury and obtaining promising results would shed light on the future clinical studies. Thank you.
Wonderful, Pınar, for this nice presentation and keeping the time well. Is there any questions from the audience? Ibrahim or Psycho, do you have any questions, or Lucas?
No.
No, no.
Then maybe we can have the questions at the end of the session. It will be better. So the next, okay, we can continue. We can go on.
May I ask, Lucas, may I ask the support desk to give us the time for the presenters? To start with time.
Probably Lucas.
I will send him a message. Okay,
Yeah,
I would like to announce the next presentation. Chararesi Erika from Italy, skull-based and craniofacial approach to minimize approach-related morbidity for intracerebral complex neoplastic and vascular lesions. So Erika, she's here.
Yes, I'm here. Good evening.
Welcome, please. You
Good
can
evening.
start with your presentation. Good evening.
Sad da mu kažem.
Okay. No, on that. Sorry. Okay. Good evening, America Carassi. Thank you for this opportunity. I'm presenting our experience on skull-based and craniofacial approaches to minimize approach-related morbidity for intracerebral complex lesions. The goals of skull-based surgery have changed over the past decades with emphasis on minimizing morbidity and maximizing the quality of life of patients. Minimal invasive surgical approaches are supposed to have a less impact on morbidity and on quality of life, but if these approaches are wrongly selected, the label minimal invasive may turn out to be a misnomer, leading just to a different morbidity profile rather than a reduced morbidity. The skull base has been defined for its complexity as a no man's land. Therefore, a multidisciplinary approach and therefore a collaboration with ENT surgeons, maxillofacial surgeons, and so on, it's important to tailor the strategy to the patient. We can choose among different approaches, the traditional open, transcranial, transfacial, or the minimal invasive, such as the endoscopic and the nasal approach, or the combination of these. But the important thing is that no approaches are fancy or obsolete when the goal is to reduce the manipulation on surrounding healthy tissues. This is the case of a 31-year-old male who presented with headache and diplopia. It was affected by a giant cell tumor of the clivus. We can see on the MRI that despite the big size of the lesion, its location on the midline allowed us to select a minimal invasive approach to resect in a complete way the tumor, and the patient fared well and he had no recurrence during the follow-up years. On the other hand, this is the case of a 17-year-old girl who presented with a progressive left hemiparesis, dysphonia, dysphagia, and headache. She was already been treated with an occipital cervical fixation and a proton beam therapy, and she was affected by a recurrence of chordoma. We can see on the MRI that the anatomy of the craniovertebral junction has completely been subverted by the tumor, and we can see also a compression on the midbrain and an infiltration of the parapharyngeal tissue on the left. Therefore, we select an endoscopic endonasal approach as a first step to decompress the bulbomedullary junction. We can see on the video we performed an inverted U-shaped flap of mucosa, and since the anatomy was completely subverted, we used the intraoperative neuronavigator to better understand the anatomical landmark. Here we're using the neuronavigator and the ultrasound osteotome to debulk the lesion, and we drill out the infiltrated bone. Then we are detaching the tumor from the underlying structures. This is the intradural component, but the most important thing is that the straightforward corridor provided by this approach allowed us to decompress the vertebral artery that was completely encased by the tumor, minimizing the risk of injuring the vessel. Okay. And we can see at the end the structures completely decompressed. On the CT scan, we can see the decompression of the bulbomedullary junction, but the persistence of a lateral residual of the tumor. And therefore, in collaboration with the maxillofacial surgeons, we performed an extended open transmandibular transcervical approach to resect the residual of the tumor and to reconstruct the craniovertebral junction. And as we can see on the postoperative CT scan, the reconstruction of the craniovertebral junction was made with 2 heterologous bone splints to facilitate the subsequent proton beam therapy. In conclusion, we can say that the surgical route must be tailored on tumor and patient's characteristics, that minimally invasive approaches should be always preferred if possible to reduce the approach-related morbidity, but open craniofacial approaches, alone or combined, remain a valid option for complex skull-based lesions and should be therefore part of the neurosurgeon's armamentarium. A multidisciplinary strategy is essential to offer the best treatment to patients. Thank you very much for your attention.
Thank you. Tomislav? Turn your microphone on.
Yeah, thank you, Erika, for your nice presentation. And as Ihsan said, we will take questions at the end of the session. Okay. So it's my pleasure to announce the next speaker. This is Mr. Dey Subir from India, talking about autonomic dysfunction following mild head injury. Is Dr. Subir here?
Yeah, I'm here.
Good. So you can start your presentation, please. You have 6 minutes.
Yeah, the topic, good evening, everyone. The topic is autonomic dysfunction following a mild head injury. This alteration in the autonomic function is very well recognized in the severe as well as the moderate head injury. The topic is about the mild head injury. I would like to concentrate specifically on mild head injury, whether there is any autonomic dysfunction is there or not. What is autonomic dysfunction or dysautonomia or brainstem attack? It is basically a transient alteration in the acute recovery phase, which the patient is characterized by tachypnea of more than 30 breaths per minute, tachycardia of more than 120 beats per minute, systolic blood pressure more than 160, or increase in temperature with posturing or increase in muscle tone or profuse sweating. These 7, any 5 of them, if present, is being diagnosed as a case of autonomic dysfunction following a head injury. So my aim of this presentation is to study the natural history and find the outcomes in a case of a mild head injury, what happens if there is autonomia. It's a retrospective study which is compared with the control, which is age and sex matched control has been taken. It's done at the tertiary at the Armed Forces Center in the Teaching Hospital in Pune in India, and studies of 6 months, and the sample sizes of 20 patients. The inclusion criteria includes the mild head injury patients who have reported within 24 hours and who has developed the features of dysautonomia. The control group are the same mild head injury, but there are no features of any dysautonomia. And mild head injury, I mean, if the GCS is between 13 to 15, post-traumatic amnesia of less than 24 hours, and having a loss of consciousness of less than 30 minutes. The exclusion criteria includes all the patients with comorbidity of any seizures, psychiatric disorders, cardiac disease, or any previous history of any traumatic brain injury. These patients were evaluated for their age, sex, Glasgow Coma Scale, blood pressure, respiration rate, pulse rate, and mode of injury. Dysautonomic symptoms were evaluated by the symptom of sweating, the tone, the posturing, the hypertension, and the pulse. The outcome parameters were mainly the mean hospital days, mean high density unit days the patient has spent in the hospital, the mean Glasgow outcome score, the mean functional independence measure score, and to add on to the symptoms, the headache and amnesia, which is a part of the post-concussion syndromes. The outcome were measured at 10 days, 1 month, and at 6 months. So the results were found that the mean age between the control as well as the study was almost the equivalent, which was not significant, which was around 30.2. The Glasgow outcome score was also the same. Sorry, the Glasgow Coma Scale was around 14, which was also not significant. The sex and the mode of injury was also the same. However, now if we see the dysautonomia functions, the patients with dysautonomia and the control, when they were compared with the Fisher test, they were found significant. So to say, this is the picture of a patient showing sweating. If we see the sweating is unilaterally present. And if we see the pulse rate, it is around 131 with the respiration of 30 per minute. So she almost fulfills the criteria of dysautonomia. So to see the outcome measures, the mean hospital days spent by a patient of dysautonomia was around 15 days, and a control was around 10 days, which was significant. And the days spent in the high density units were around 12 for dysautonomia and 4 for the control, which was also significant. And the mean Glasgow outcome score was 4 at the end of 10 days, whereas 5 in the control patients, which was also significant. And the mean functional independence measure score was 110 at the end of 10 days, and 126, which was almost the full at the end of 10 days, which was significant. However, the post-concussion syndrome, which the symptoms were not that significant, mainly the headache and amnesia. So at the end of 10 days, if we see the Glasgow outcome score of the control as well as the study group initially had 4, which improved over a period of time. At the end of 1 month, it was almost equivalent. If we see the mean functional independence measure, it was at the end of 10 days, it was 110, which gradually improved. And at the end of 6 months, it's improved to 120. However, it has not come to the normal as compared to the control patients of 126. So to say, this paper is a supportive evidence of dysautonomia in a case of mild traumatic brain injury. The patients of dysautonomia in case of mild head injury has a long stay in the hospital and develops persistent headache. It is associated with poorer functional outcome. However, this study is only done in mild head injury. So the entity of autonomic dysfunction does exist in mild head injury. Early recognition and treatment of this condition is recommended to start early cognitive rehabilitation. So the research on the autonomic dysfunction following a head injury has been there, but there's no standardized protocol, standardized treatment to it. First, whether it exists or not is a question. So this is a supportive evidence, and this study says that it does exist, and the outcome is not good as compared to the control patients. And the systemic evaluation of the treatment regimes and protocol for early rehabilitation are required to optimize the outcome of the patients with dysautonomia. Thank you so much.
Thank you so much, Suber, for your nice presentation. The next speaker is from Greece, Lambriano Santoula. The topic is management of patients suffering with pediatric mild head injuries, a single institution experience. Present.
Good evening. I'm Lambriano Santoula. I'm a neurosurgeon resident at University Hospital of Larissa in Greece. And today I'm going to present you our experience for the management of mild head injuries in children. I have nothing to disclose, but I'm still hoping. As we all know, mild TBI in children is a growing public health concern. From 2005 to 2009, children made approximately 3 million emergency department visits for mild TBI in US. Interestingly, only 4% of them were admitted in the hospital. Clinicians' awareness of the management of the guidelines for the management of TBI and their ability to identify mild head injury mitigates the unnecessary exposure to imaging modality, so clinical guidance for professional care is critical to improving health and safety in pediatric population. So having this in mind, the aim of our study was to report the incidence of emergency department visits of children with mild head injury, estimate the unnecessary exposure to radiation, and of course, estimate the overall cost. A total of 693 children with mild head injury over a 2-year period were included in our retrospective study. The mean age was 5.1. The admission GCS score was 14 or 15 out of 15. 275 children underwent scalp radiographs, but only 9 of them had a possible skull fracture. CT scan was obtained in all children with possible skull fracture, but only 4 of them had imaging findings on CT scan, such as exoparenchymal hematoma. None of the patient needed neurosurgical intervention. The overall cost of unnecessary imaging was estimated to be as high as 6,000 euros, approximately 3,000 per year. Here we have one of our patients with a skull radiograph positive for fracture, as we can see here, and the following CT scan, which confirmed the fracture and also depicts the exoparenchymal hematoma. So to summarize, from the total of 693 children, 275 underwent skull radiographs. 9 of them underwent CT scan, but only 4 of them had positive CT scan. It is worth noting that the CDC suggests not to use scalp radiograph in the diagnosis of pediatric mild TBI. Literature also reports that scalp radiograph is not the optimal tool for diagnosing a single skull fracture, as its sensitivity is only 63%. On the other hand, CT scan better detects intracranial injury and characterize the skull fracture, making it the more appropriate tool when it's clinically indicated. In conclusion, we have to improve our diagnosis and management of mild TBI in children by using the latest published guidelines in order to avoid the unnecessary radiation in our children. Equally as important as the use of guidelines is a multifaceted approach to its implementation, such as parents and community providers education. Thank you very much. Hvala.
Thank you, colleagues. So I would like to invite now our colleague Nebojša Lasca from Serbia. The talk is about the systematic review of intraparenchymal meningioma. Nebojša, please.
Thank you for considering my my paper for this Young Neurosurgeons Award, I will talk about intraparenchymal meningiomas today. Typical meningiomas are the most common primary non-malignant tumors of the central nervous system that present usually in the adult population, and they're rare in the pediatric population. They are thought to originate from the arachnoid cap cells, and are usually dural-based tumors with the typical dural tail sign on the MRI imaging. They may also develop without the dural attachment, as we all know, in the pineal region, intraventricular region, and possibly in the sylvian fissure. Today, I will talk about the specific entity of intraparenchymal meningiomas that are thought to develop from the pile cap cells that enter the brain during the development, and some further sporadic mutations possibly induce their proliferation and then the creation of intraparenchymal meningiomas. To identify all the cases, we review the PubMed and Web of Science databases, and also references within the identified papers, and also extracted data from the case reports, case series, and cross-sectional studies in English language. We had no restrictions regarding the year of publication and excluded the secondary intraparenchymal meningiomas. As you can see in this graph, that is important to see that usually neurosurgeons didn't consider the preoperatively meningiomas when they saw the imaging of the intraparenchymal meningiomas. They usually thought that it was either gliomas or metastatic tumors, or these rarer entities here shown on the right-hand side. In total, we identified 50 cases published from 1961 to 2019. The mean age was 21 years, and there was an inverted male to female ratio, almost 2 to 1. In pediatric population, we usually saw the epileptic seizure as the most common presenting symptom that was typical for pediatric population tumors. And in adult population, they presented with the signs of increased intracranial pressure, and also with the epileptic seizures. The most common localizations were on the cerebral convexity within the frontal, temporal, and parietal lobe. However, imaging characteristics revealed that there was no uniform presentation on T1 weighted, T2 weighted, and T1 post-contrast imaging.
Colleague, please. We see only first slide.
Yeah.
Can you move the slide so we see that you are going through the presentation?
Well,
but we see only.
Yeah, that's
slide.
right. You are right, Ibrahim. I am seeing the first slide too.
All the time.
Probably there's a problem with the.
Please start presentation on your PowerPoint software.
Should I restart?
Can we start presentation again? Because slides didn't follow the presentation.
Okay.
All the time being first slide.
So can you see the second slide now when I change it like this?
Change it now.
Put the
but
full
there is also
screen
option to show us on the whole screen, full screen.
Full
Do you
screen,
manage how
please.
to put on full screen?
Yep.
Okay, can you see the next one right now?
Yes, the slide number 2.
Are they moving?
Sorry? No.
Okay, perhaps it's better to use.
Now it is.
Yeah, but I shouldn't use the full screen, right?
Let me help you, Lasca.
Yeah.
Go up to the slideshow taskbar.
Yeah.
Right, yes, and then left, setup slideshow. Left.
Left.
No, right now. Yes, right, yeah, here. Then choose second one, up left. Second one, that. Okay. That's it. Go to the slideshow now.
Yeah.
Try now.
Okay. Now it
Try
is
now.
okay.
Can you?
Yeah, it works.
Yeah,
it works.
it works now.
Should I start like from the
Yes,
beginning?
please. From the beginning, because.
Yeah. Okay, can you reset the clock, maybe? Thank you.
We see now it's everything fine. Go ahead.
Yep.
I'll talk about systematic review of interparenchymal meningiomas. As we all know, the most common primary non-malignant tumors of the central nervous system are meningiomas that are rare in pediatric population. They originate from the cap cells and are usually dural-based tumors when reviewed on the MRI imaging. They also may develop without the dural attachment within the pineal region, also within the sylvian fissure, and also in the intraventricular region. Today I will talk about interparenchymal meningiomas that presumably develop from the pile cap cells that enter the brain via the penetrating blood vessels, and usually the spontaneous mutation leads to the proliferation of pile cap cells that develop further into intraparenchymal meningioma. We researched the literature on the PubMed and Web of Science databases and also within the references, and extracted data from the case reports, case series, and cross-sectional studies in English language with no restrictions regarding the year of publication, and secondary interparenchymal meningiomas were excluded. As you can see in this graph, meningiomas were not considered by neurosurgeons preoperatively. They were rather considered as gliomas or metastatic tumors or other rare tumors, as you can see on this right-hand side. In total, we identified 50 cases in total published from 1961 to 2019. As you can see, the population was with the mean age of 21 and inverted female to male ratio 1:2. And as you can see, the pediatric population usually presented with epileptic seizures that is usual for the pediatric brain tumors. And on the other hand, you can see that the adult population usually presented with the signs of increased intracranial pressure and also with epileptic seizures. The most commonly they were presented on the within the frontal lobes and temporal and parietal lobes. Also, imaging characteristics that we identified didn't show any specific or uniform they were not uniform or specific on T1 weighted or T2 weighted and T1 post-contrast imaging. Also, we managed to identify that these tumors presented more readily with cysts and perifocal edema. And you can see on the right-hand side on T2 imaging, the actual image of one intraparenchymal meningioma with mild perifocal edema, and also the presence of cysts within the tumor parenchyma. Also, we were able to show that these tumors are usually grade 2 or grade 3. That is not common for the typical meningiomas. Usually, the surgery was done in around 80% of patients, and surgery with radiotherapy in 7 patients. The gross total resection was able to be done in more than 2/3 of patients, and subtotal resection was able to be done in 7 patients. The overall recurrence was present in 3 patients, and 1 patient from the pediatric case had a lethal outcome. We can conclude that these specific meningiomas tend to occur at an earlier age when compared with typical dural-based meningiomas, and there was an abolished characteristic female predominance in this particular group. We can also see that WHO grade 3 and grade 2 meningiomas were predominant in this series, and also the presence of cysts and edema was more readily observed in it. However, these characteristics are not specific and cannot allow us to identify these tumors preoperatively. So I would like to emphasize the importance of routine MRI spectroscopy if it is possible to do in the center, and the role of alanine peak in the Holly spectrum as it was reported previously in this this paper. I would like to conclude that awareness and careful analysis of preoperative data may help maintain a reasonable amount of suspicion with typical interaxial lesions. And with this, I will conclude my presentation and send you greetings from Novi Sad and from me and from my colleagues from the Clinic of Neurosurgery at the Clinical Center of Vojvodina. Thank you very much.
Peter, can you announce next presenter?
Yes, thank you very much. despite the technical difficulties, we concluded this. And next presenter is Mavrovonis Georgios from Greece, and the topic is postural ergonomics and work-related musculoskeletal disorders in neurosurgery. Lessons from an international survey. Please, the stage is yours.
Thank you. Can you see the presentation right?
I hope. Let's move to the second slide.
Let me see. Is that okay?
Yeah.
Yeah, thank you. My name is Mavrovonis George, and I want to thank the organizing committee for giving me the opportunity to present the result of our survey on postural ergonomics and work-related musculoskeletal disorders in neurosurgery. I have nothing to disclose. So some background information: work-related musculoskeletal disorders have a prevalence of around 20 to 70% amongst surgeons and can lead to carpal tunnel syndrome, lumbar or cervical radiculopathy, varicose veins, rotator cuff disease, and a lot of other disorders. And they affect both the surgeon by decreasing the ability to operate and the patients by increasing their waiting time on the operating lists. So despite their prevalence, there is limited literature available on the subject in both surgery and in neurosurgery specifically. So the aim of our survey was to examine the prevalence of work-related musculoskeletal disorders amongst neurosurgeons, identify possible risk factors in developing such disorders, and investigate the views and attitudes of neurosurgeons on the subject. To do that, we conducted a questionnaire-based cross-sectional survey using the Google Forms platform, and our study period was between June 3rd and August 11 of 2020. We distributed our questionnaire using the email and social media platforms to question our participants on 4 major areas of interest: demographics, health-related information, procedure-specific information, and personal views and attitudes. Our results: 409 neurosurgeons responded with an almost 5:1 male-to-female ratio, which is to be expected. Most of our participants worked in Europe in academic public hospitals, and the most common operations performed were craniotomy for convexity tumors and open lumbar basic spine operations. Notably, almost 90% of our participants had experienced work-related musculoskeletal disorders at least once in their career, and 60% of those have sought treatment for that. Notably, 99% of the participants continued working despite their musculoskeletal problems. The most commonly affected muscles, as you can see on the heat map, were those of the shoulder, neck, and back regions, and were mostly affected after surgery. In our univariate analysis, we couldn't find any associations between the development of work-related musculoskeletal disorders and age, gender, tenure, average duration of operation, operating time per week, operation type, and surgical approach. Almost 90% of surgeons agreed that hospital management should invest more resources to equip the operating room more ergonomically, and the majority of surgeons agreed that ergonomics is an underexposed area in both surgery and neurosurgery. Finally, 78% agreed that neurosurgery residency training curricula should be revised in order to provide surgical ergonomics education. So to conclude, postural ergonomics and work-related musculoskeletal disorders are important topics and deserve more attention from the neurosurgical community, both in the day-to-day practice and from a research standpoint. A significant percentage of neurosurgeons has experienced those disorders at some point in their career, and further research should be conducted to shed more light on specific areas of interest, such as postural ergonomics and operating theater equipment. Finally, trainees and young neurosurgeons should be educated on the subject and receive specific training to adapt healthy attitudes and minimize the risk of developing those disorders. Thank you for your time.
Thank you, Dr. Mavrovounis. It was a really nice presentation, and the questions will follow after all the participants give their lecture. So we'll move on with Dr. Pava Bhavia from India, and he will talk about the gamma knife surgery regarding the meningiomas. So please, you can start.
Great, thank you. So just a correction, it's a she. That's not
I'm sorry.
It's fine, totally fine. Let me share my screen. Is the screen visible?
Apologies once again.
Oh, it's fine. Is the screen visible?
Yeah.
Okay, great. So, good evening, ladies and gentlemen. I am Bhavya Bhava, a second-year medical student at UCMS New Delhi, India, and my mentor for the study was Dr. Deepak Agrawal, who's a professor at the Department of Neurosurgery, AIMS, New Delhi, India. The study is titled as Correlation Based on WHO Grading with Tumor Control in Clinical Outcome Following Gamma Knife Radiosurgery in Meningiomas. So WHO basically grades meningioma on the basis of its degree of aggressiveness into three major grades. It's benign, atypical, and malignant, with the majority of the meningiomas belonging to benign category. 4.7 to 7.2% are atypical in nature, and 1 to 2.8% of the total meningiomas could be malignant. The factors that determine the recurrence of meningioma are the extent of resection and the Simpson histological grade. Tumors are mostly situated in critical areas where there's higher chances of invasion of the blood vessels and neurostructural that would limit the complete resection of the tumor. However, even after complete resection, the disease-free survival after 5 or 10 years is not even 100%. The objective of the study was to study the effect of gamma knife and meningiomas based on WHO grading in terms of tumor control and the final clinical outcome. It was a retrospective study that was carried over a period of 12 years, where the inclusion criteria of the patients involved GKRS after resection and whose histopathology slides were available for review. However, the patients were excluded if there was no histopathology slides for review, or if there was histology but the follow-up was less than 6 months. The outcome was assessed in terms of tumor control and progression, where the control was defined as the size which remained same or decreased, or when it progressed, which was an increase in the sizes compared to prior to GKRS on CE/MRI. So a total of 440 patients came to our department, where of which 235 received secondary gamma knife, of which 177 had a biopsy that was available. And the total patient that was available that were included in the study was 137, and 40 were excluded on the basis of our inclusion and the exclusion criteria as defined before. The statistical analysis was performed, and a p-value of 0.05 less than was considered to be statistically significant. Kaplan-Meier curve were calculated for tumor progression-free survival and overall survival between WHO grade 1, 2, and 3 groups. The mean age group of presentation was 42.26 years, and the maximum patients were in the 4 decade. 52 were males and 85 were females in the study group. Most of the patients were asymptomatic, and they had no deficits as well. Now, this is a very important table that I would want you to focus upon, because this is telling us about the differences in the different 3 grades of meningiomas on the basis of their gamma knife characteristics, the follow-up, and the tumor control. So the tumor volume kept on increasing, as we can see here. Subsequently, the radiation dose on the discretion of this neurosurgeon were increased solely. And fortunately, at the end of the follow-up of 41.14 months for grade 1, a tumor control of 96.3% was achieved for grade 1 and 10% for grade 3 and 62.5% for grade 2. Now, this is a curve where we're just telling us about the overall survival estimates. So at the end of 5 years, which is somewhere here, the WHO grade 1 patients had a survival rate of approximately 100%. For grade 2, they had approximately 75%. And for grade 3, it was approximately 45%. Talking about their tumor progression-free survival curves, the WHO grading at the end of 5 years, it's somewhere here, the progression-free survival PFS for grade 1 was approximately 96%, 50% for grade 2, and 22% for grade 3. At the end of 10 years, it was approximately 50% for grade 1, 38% for grade 2, and nil or 0% for grade 3. So approximately 11 patients out of 137 died, of which 4 patients died because of meningioma recurrence, 1 patient each in grade 1 and 2, and 2 patients in grade 3. The factors that were statistically significant in predicting PFS after GKRS in grade 1 were prior radiotherapy and repeat surgery. For grade 1 and for grade 2 and 3, it was high-grade tumor and radiotherapy prior to GKRS. On finding subsequent research, age, sex, and symptoms grading were found to be statistically insignificant. Now, this is a comparison to the similar studies. Fortunately, ours is the 4th study in the world to be done to look at the correlation. However, none of the studies have separately mentioned anything about the follow-up or the dosage forms, which is quite misleading, and hence the results have been shunned out by the international authorities. We conclude that this study is basically compared on the various grades of meningiomas along with the gamma knife, and that patients with WHO grade 1 radiation therapy prior to GKRS and repeat surgery were the predictors for poorer outcomes. And in WHO grade 2 and 3 meningiomas, no factors were affecting tumor control except the histology itself. Hence, we could say that gamma knife is effective even in higher grades of meningiomas, and we demand more research work to be done. Thank you for your time and patience, everybody.
Thank you so much, Pahwa, for this nice presentation. If we will have questions at the end of the session, we will have. The next speaker will be from Croatia, Rotim Ante. The topic is selection of management strategies for aneurysms of middle cerebral artery, a single institution experience.
Good evening. Can you see the screen, the presentation?
Yes, we can, but it will be better to make it whole screen.
Okay.
Yeah, please go on.
Okay, thank you. So just a quick introduction. My name is Dr. Rotim from University Hospital Centers Sisters of Mercy in Zagreb, Croatia. And before I start, I would just like to thank Professor Rasulic and the committee for taking me into account for this award. So what I will do is give you...
Ante, I'm sorry, but we are seeing the first slide currently.
Now,
could you please the presentation as a whole screen?
It is full screen for me. You see the second slide?
No, it's still the first slide is.
Just a second.
I'm not sure. Psycho, are you seeing the same?
I'm seeing only the first slide. But
yeah, me too. So
maybe Ibrahim knows what he can do with the slides.
Ante,
I'm listening.
Now Ibrahim,
I will help you.
Okay.
So go up to just a second. Idi gore na dia projekcija. Mislim da je, pošto ti je na hrvatskom, još desno. Tu. Postavljaj to. Idi na hrvatskom, ne znam, vidi ovo drugo gore lijevo, gledaj to.
This one.
U redu, yes.
Dobro.
Yes, okay, now show us full screen.
Better.
Wonderful.
Okay,
I
thank you very
understand,
much.
But it's working.
That's it, my jury are here.
Okay, thank you. So anyways, I'll just give a brief talk about how we deal with aneurysms, specifically ACM aneurysms in our institution. So as we all know, there are actually two in general methods. The first one being surgical one or clipping, and the second one being endovascular treatment, including either coiling, stenting, flow diversion, or web, or any combination of those. So I will just likewise give you some of the data we had from our study also. So the entry parameters, like we had some entry parameters like aneurysm location, be it M1, bifurcation M2, or any of the distal segments, then morphology, meaning neck and fundus and both their ratios, and then the presence or absence of subarachnoidal hemorrhage, of course, the clinical status, which includes Glasgow Coma score and Hunt-Hess score. complications in both of these groups, and the outcome measured in modified ranking scale and extended Glasgow outcome score. So this is the first group, and in the first graph you can see that we had around 45 patients who were treated in a surgical conventional way. Most of those aneurysms were situated on M1, a couple of them on M2, and we had I think 2 patients who had an aneurysm both on M1 and M2. And on the right side, you can see that most of these aneurysms were located on the right side. So the next 2 graphs actually show the correlation, the p-value, of course, being significant between the Fisher score, the entry Fisher score, and the modified ranking scale and Glasgow extended outcome score. So the higher the Fisher value initial, the worse the outcome is, of course, and the same goes for the MRS, where you can see it on the lower graph. So the higher the higher the Hunt-Hess, the worse the outcome is, meaning the lower the GOSE score is. The same data we have for the second group, which was treated endovascularly. So the data shows that we had around 30 of those patients, and I'm talking about a period of around 3 years. We had a COVID situation, a bit less patients in the last year. On the second graph, you can see basically this as on the that was treated surgically, so, which is basically self-explanatory. It says the higher the Fisher score is, the worse the GOSE and MRS outcomes is. The same goes for Hunt-Hess score, and these graphs actually show us not the correlation but the comparison between the 2 groups. And it is expected because the situation is next. We had around 30% of patients in a surgically treated group who had the presence of SOX, so their entry scores were a bit better than endovascular group, where we had, I think, over 60% of patients who had subarachnoid hemorrhage. The age is pretty much the same, so no significant difference. There was a significant difference between entry Fisher and Hunt-Hess scales. There is around half a point of difference between those 2 groups. There was no significant difference between the size of the aneurysm, be it either neck or fundus, so maybe a millimeter of difference. And the outcome scores were also statistically different, but that is expected because the initial symptoms of those surgically treated were because they had not so many of them had the presence of SAH. And just a quick conclusion. So how we do it, the aneurysm location and the morphology were those parameters that were recognized as determinants of management selection, regardless of the rupture or clinical status. As I said, we had 30% of ruptured cases in the surgical group and around 60 or even more in the endovascular treated group. Endovascular patients, of course, experienced less stable occlusion. Around 30% of those patients after a year need reintervention, and of course, were more prone to revascularization complications. And both microsurgical and endovascular treatments are equally successful, having low morbidity and favorable outcome in, I have to mention, selected patients, because most of those who had, let's say, wide neck bifurcation aneurysms were treated, of course, surgically, but we had a couple of patients in the endovascular group who were actually treated with those new devices, endosaccular devices like Webb, which also shows a relatively high rate of occlusion after 1 year, which is, I think, over 80%. And thanks for your attention, and questions later, I suppose.
Okay, can we start with the next presentation? Nissan? Okay, Filip Vitošević from Serbia. He will talk about the clinical morphological parameters associated with the risk of rupture of the anterior concave artery annulus. Philip, please, you can start with your presentation, please.
Okay, can you see my screen?
Yes.
Okay. Dear colleagues, I'm honored to present the results of my recent study about morphological and clinical characteristics that are associated with the intracranial aneurysm rupture. And today I will focus on anterior communicating artery aneurysms. ACOM aneurysms account for more than 30% of all intracranial aneurysms and are commonly related to aneurysm rupture. And patients with ruptured ACOM aneurysms often have poor outcomes and higher incidences of vasospasm and neurological deficit. So knowledge of risk factors for rupture is crucial for managing and counseling patients with ACOM aneurysms. Although size is the most common parameter used to evaluate aneurysm rupture risk, several other complex parameters, including aspect ratio, size ratio, aneurysm inflow angle, have a greater association with rupture than the size alone. So we analyzed aneurysm morphology as well as socio-demographic and clinical characteristics in patients with ACOM aneurysms to investigate the risk factors contributing to aneurysm rupture at this specific location. A total of 219 patients with ACOM aneurysms were admitted to our hospital in a 5-year period. And after application of study inclusion criteria, 153 patients were enrolled finally in the study. Morphological parameters included 13 variables like aneurysm size, width, neck diameter, height, aspect ratio, size ratio, bottleneck ratio, height-width ratio, aneurysm angle, inflow angle, branching angle, and many more. First table that I'm showing summarizes the demographic and clinical characteristics of patients according to the aneurysm rupture status. And we can see that among ruptured aneurysms, there was a higher proportion of male patients. And among unruptured aneurysms, there was a higher proportion of patients with hypertension under control and those with heart disease. And this second table summarizes the morphological parameters of the aneurysms divided by the aneurysm rupture status. And aneurysms with smaller neck diameters, greater aspect ratios, height-width ratios, and larger aneurysm angles. Also, presence of daughter sex, irregular wall morphology, and irregular shapes were significantly associated with aneurysm rupture. This table shows the logistic regression results, and the results show that male gender was associated with almost 3 times higher odds of rupture. And hypertension under control was associated with almost 10 times lower odds of rupture. Higher aspect ratios was associated with 3 times and higher height-width ratio with almost 4 times higher odds of rupture. In the multivariate model, controlled hypertension, presence of multiple aneurysms, and larger neck diameter reduced the odds of ratio, while irregular wall morphology increased the risk of rupture. This figure shows predictors of rupture in multivariable model graphically also. In discussion, I want to say that our study showed that ACOM aneurysms more often ruptured in male patients. And to our knowledge, this is the first study to report such results. In our study, in the group of patients with hypertension, the ones with unstable hypertension were more likely to have ruptured aneurysm. And this supports the relationship between erratic blood pressure levels and the rupture of cerebral aneurysms. Like other studies concerning intracranial aneurysms, we showed also that ruptured ACOM aneurysms had a significantly higher aspect ratio and height-width ratio values. And the plausible cause would be that in our experience, ruptured ACOM aneurysms have more elegant shape. And like the study of Dar et al., we also found association between aneurysm angle and the rupture of ACOM aneurysms. So in conclusion, I would like to point out that controlled hypertension represented a significant protective factor from ACOM aneurysm rupture, and it is a risk factor that can be controlled by medication therapy. echomannerisms in male patients and ones with smaller neck diameters, greater aspect ratios, height-width ratios, larger aneurysm angles, and irregularities in shape and wall morphology are associated with higher risk of rupture. These socio-demographic, clinical, and morphological characteristics are easy to evaluate in everyday clinical practice and should be used in risk assessment of patients with ACOM aneurysms. Thank you very much.
Thank you, Philip, very much. That was really very, very good. And the last presenter is Yakar Fatih from Turkey.
Hi.
Hello, stage is yours.
Thank you. Can you see my screen?
Yes.
Yes. Dear colleagues, first of all, I would like to thank the organizing committee for the opportunity to present our study in this platform. Our subject is fetal posterior communicating artery a target for thromboembolic events during digital subtraction angiography? We have no conflict of interest. The fetal PCOM artery, if PCOM artery segment diameter is wider than PCA, it means fetal PCOM artery, FPCA. Its incidence is reported 11.46% in the literature. In the first image, we see adult PCA, and second one is partial FPCA, and it originates from ICA with a small or atretic connection with basilar artery. In the third image, it is complete fetal PCA, and the posterior cerebral artery entirely originates from internal cerebral artery with no connection to basilar artery. I would like to talk about FPCA hemodynamics. It creates an imbalance in blood flow, and it produces left-right hemisphere asymmetry on perfusion imagings. In a large study, they evaluated 4,518 patients who underwent MR angiography, and they conclude that FPCA was significantly more often related to aneurysms developing at this site PCOM artery. Fetal PCA has higher PCOM aneurysm incidence and larger size of aneurysm necks. Fetal PCA is a fetal variant, and less major vessel disposition leads to a weaker vessel wall. So it prompts to develop aneurysms and leads to delayed regrowth following treatment. Some authors conclude that it increases the recanalization of coiled PCOM aneurysms, but some other authors defend the opposite idea. They say it is not related with the recanalization of coiled PCOM aneurysms. And also, flow diverter treatment is ineffective at treating PCOM aneurysms if it's associated with a fetal PCA. And at the same time, the literature advocating that the presence of FPCA increases the thromboembolic events during the endovascular therapies. Here, there is an FPCA case. The dotted line shows the direction of blood flow. Also, we see adult PCA and fetal PCA, and we speculate that the blood flow is following the dotted line. Our hypothesis is that FPCA acts as an early ICA bifurcation due to altered blood flow characteristics. And the FPCA that runs almost parallel to the MCA becomes a target, as most stroke cases occur in the MCA. And we searched our database, and we evaluated 249 patients. We had 45 FPCA variants, and our stroke interventions for 21 patients. We found no FPCA variant on stroke sites and no FPCA occlusion in our series. In the literature, increased stroke burden has been described in postmortem studies of patients with FPCA, and some other studies failed to demonstrate increased risk for cerebral ischemia in patients with FPCA. Also, 5 recent major randomized trials showing the benefit of mechanical thrombectomy in anterior circulation occlusions did not include FPCA occlusions. And a retrospective and multi-center study was published in this November about mechanical thrombectomy of FPCA occlusion. And they state that at 19th days, 48% of their patients were functionally independent. They had only 25 patients. Shaban et al. Presented a large retrospective case series. They had 536 stroke patients, and they state that patients with complete FPCA had less small vessel and more large vessel strokes than patients with no FPCA and partial FPCA. In conclusions, current consensus does not exist on whether FPCA increases the overall risk of stroke independent of other factors. And we theorized that the presence of FPCA may cause PCOM artery to become a target for thromboembolism during catheter angiography due to the hemodynamic changes. And the neurointerventionists should be aware of this situation. Thanks for your attention.
Okay. I will put the screen and you can announce the winners. Dun, dun. Here you go.
Whoa, we have several winners.
We had the problem to choose the best. There were many good presentations. We have been in bad position, but at the end, I think so we agreed for those names. So if it's possible to give two first, 2 second, and 2 third prizes instead of 1 for. So it's up to you. It's up to you.
Well, it's up to all of us. Since you have this decision, I don't have any other choice than to pronounce that we have winners of our competition in terms of receiving awards and certificates for the best papers and some, let's say, symbolic award for this participating in our events. So this forthcoming events, we have a European Congress of Neurosurgery in October next year. We have our next year annual meeting with Serbian Neurosurgical Society and SENS. And of course, we have a Silk Road educational course, spine surgery. So as you choose the winners for the first and second and third prize, you put it in this row. Let it be like this. And I congratulate the winners for this award. So winners should receive the abstracts, should receive the certificates, and of course instructions for how to uptake their award for our forthcoming events. I congratulate once again to all of you, and practically we are all the winners. You are the winners, like participants in this session. Jury is a winner because jury have a difficult decision and put me in a difficult situation to have 6 winners. So this is something which consider that quality of the abstracts were excellent and presentation also. So thank you very much for this. And I just want to ask Professor Omer Hodžić and other members of the jury to close the session. Congratulations once again.
Thank you, Lucas. I invite those who weren't be lucky today to continue follow the SENS and dance courses, and the next time I hope and believe they will win. They had all of them very nice presentations. Thank you.
Thank you. So we are closing the session, and stay with us for a few minutes. So we are having our closing ceremony, and thank you once again for your wonderful participation. participation. Congratulations and cheers. All the best.
Bye.
Bye.